All right, so learning objectives. At the end of this webinar, you'll be able to describe 3 strategies that physicians and teams can employ to proactively manage demand for appointments, and describe 2 strategies for increasing supply of appointments through utilizing team and protecting physician time. Without further ado, I'm going to hand it over to Janet to get us started.
Hi, everyone. I wanted to start off by saying we recognize how hard it is for family physicians right now. We have huge demands on our time and to provide good service to all our patients. And what we want to do in this webinar is maybe just give you a couple of tips that maybe you've thought about, maybe you haven't, about tweaking some minor things in your clinic that maybe will help you provide great care to your patients. But we recognize that everyone is trying to do more with less right now. So we appreciate all that you're doing. Okay. So just a review that demand refers to all the work that your panel of patients generate. So demand is your panel size and the number of visits that your patients make in a year on average. So I'm going to use some really basic numbers so that we can kind of keep some ideas in mind. So if you had a panel of 1,000 patients, and if the average return visit rate was 4 visits per year, your demand would be 4,000 visits per year. Now on the supply side, so supply is how much appointments you have available for your patients. So if you worked 200 days a year and you saw 20 patients per day, that would be a supply of 4,000 as well. So your demand and supply would be exactly equal, and water would flow through this pipe really nicely. But what happens if your demand goes up? So either your panel size increases or your patients become more complex and you're doing more visits per year. And you can see what happens is you start to get a backlog in that middle area of the pipe. So the water doesn't flow out as easily. And what happens if supply shrinks? Well, the backlog gets worse, and that's what happens. So supply can shrink if you work less or if you have a lot of no-shows. Those are things that might shrink your supply, not give you as much capacity to see your patients. So our only options to deal with this or to cope with this is to either increase our demand or use our supply more effectively, optimize your supply, because we all know that most of us are working as much as we feel we can right now, and we can't really work more. So it's really about working better, not more. And maybe there's a few things that we can do to reduce our demand. So that's what we're going to talk about today. Just a few little tips and things that you can maybe think about for your own practice to reduce your demand or increase your supply. All right, so we're going to go through these in more detail. So the first one is to think about your appointment types. So traditionally in the past, all our appointments were done in person, but now we have a few other options. We can do appointments virtually, or we can do send messages to patients via patient portal if your EMR has one and if you use it. So, think about, do I need to see this patient in person? Could you review lab results either virtually or with a quick message via the patient portal? Do you even need to see the patient to do prescription refills? Can you send it straight to the pharmacy when they ask you and do it that way? Chronic health conditions, can you follow up another way? So those are just some things to consider. Now, my friend Jarrett always has some things that he wants to bring to my attention. So Jarrett, what do you have for me today?
Yeah, so I know that there's all this nice talk about changing the way I do it, or maybe that patient doesn't need to come in, but I'm a fee-for-service doc, and I make more money when I see patients in person, even for quick things. The virtual codes don't pay as much. So it's really challenging for me to want to do something virtually. Why would I really be interested in that?
Okay, good point. And we know that a new fee model will be part of the solution to this problem. But don't forget that if you send a quick message via the patient portal, you can bill for that. And then that will open up a future appointment. So you're actually going to be financially ahead. Patient portal visits pay $20 and those add up, and then it opens up some future appointments. So that would be my answer to that one. Moving along. Think about how many times you need to see a patient in a year. And this is just an extreme example that if you saw a patient 6 times a year and reduced it to 3 times a year, and if you did that for 100 patients, you'd open up 300 slots. So another example is a lot of physicians, when they do prescriptions for chronic medications, your statins, your blood pressure pills, etc., they do 90 pills with 3 refills. Well, that equals 360 days. And if you want to see your patient in a year, it's actually slightly shorter than a year. So if you just make the slight change to 100 pills with 3 refills, that's 400 days, and that's just over 13 months. So there's just little tweaks that you can do that make a difference. Jarrett, what do you got for me now?
Yeah, so a concern about if I'm not seeing my patients regularly, how am I making sure that I'm staying up to date on all the little things that come up? People often have these little questions, and people are in that rhythm of they're in every 3 months, and I check on stuff. We often end up with tons of things to talk about. How do I actually know that if I start one of these things and then I say follow up with me in a year, that I'm not missing something major?
Well, that's where I think you can teach your patients to do self-monitoring and give them parameters. So for instance, if you started a new blood pressure pill, you could say, continue on it for a year unless you have the following side effects, or unless your blood pressure is not within these guidelines, and only contact me if you're having problems or your blood pressure is not well controlled. So I think the key to that is empowering our patients to do some of their own self-care. All right, so the next one is about max packing visits. And this is the idea that rather than, for a while there, all the doctors had the signs in their office that said 1 problem per visit. But sometimes you can do more at a visit, and then it saves you a visit down the road. Patients really appreciate it. So, a couple examples. If you're doing if you've got a patient with a vaginal discharge and you note that they're overdue for their PAP, do the PAP at the same time. You've got all the equipment out. It doesn't take you very long. Another example would be if a pharmacy faxes you and a patient needs 1 prescription refill, and you note that they're on 3 chronic medications, renew all 3, because the next day you're going to get another fax for another prescription and another one. Yes, you make more money if you do the 1 at a time, but it takes a lot of time. If you do it all at once, you're proactive and you can move on. What do you think about that, Jarrett?
A little scared about that idea, Jenna, especially when we're already talking about trying to get rid of some of those simple things. And I often would rely on those maybe to get behind if we're trying to pack everything in there every single time. And I'm seeing people once a year, people may have a whole bunch more than I can fit in a regular appointment slot. So I'm not sure how that might affect my practice.
Well, you're right, Jarrett. I mean, there are some days you're so far behind, there's no way you can max pack. So you have to sort of play it by ear. Sometimes you can max pack, sometimes you can't. But if you do more at a visit, then you're saving future capacity, and you'll be able to see more patients in the future. And I noted we had a comment in the chat that Inoka doesn't know anyone who actually does 1 problem per visit. It's more the opposite. So I agree. A lot of dedicated family physicians are not doing 1 problem per visit, but there are some physicians that still have those signs in their office. do try and limit it, because it is a way to make more money in the fee-for-service system. So a new compensation model will help us with that as well. And that, according to the provincial government, is coming down the pipes. All right. So moving on. So that's on the those are just some tips on the demand side. Now we're going to talk about the supply side. So this is how many patients you can, how many appointments you can offer for your patients. So the number one tip is to decrease the administrative load on the primary provider. You know, what can your team do for you and take the load off you? So years ago, I worked with one clinic, and they were looking at their mammogram screening rates, and it wasn't very good. So they started out by having the physicians, as they saw patients that were overdue, to renew, to give them mammogram scripts. And that improved their rate a little bit, but not a lot. Then they tried their nurses and MOAs, and again, it didn't work real well. But then suddenly they did a PDSA with their reception staff, going through the list of patients and contacting the patients that were overdue for mammograms. And guess what? Their mammogram completion rate went up to over 90% for their patients. So sometimes you got to think about who in your team can do certain things for you. All right. So I saw there's quite a few comments in the chat about prescribe IT. So that is something new that might help us with prescriptions going forward. And it would certainly eliminate the I lost my prescription, I need a new one, right? Which we've all had over the years. So, okay. Jarrett, what do you think about that, using your team?
Yeah, I'd certainly like to be interested in using my team more and taking things off my plate, because everybody's got too much admin stuff on their plate currently. But I know that as the physician on the team, the way it's set up currently is that I'm the person who's liable if something gets missed. And when we're talking about things that are as important as cancer screening, I'm really worried about what happens if something gets missed, somebody falls through the cracks, then that comes back, and that's a big miss on my part. So I'm just not sure that I feel super comfortable with the idea of delegating more of these tasks. What could I do in that situation?
Well, you're right. You are responsible, but that doesn't mean you can't get help from your team members. So I looked up a statistic for you. In a recent study published by the American Academy of Family Practice, it takes 26.7 hours per day for a physician to provide preventative care, chronic care, acute care, and documentation and inbox management for a panel of 2,500 patients. So, I mean, well, there obviously isn't 26.7 hours in a day. So we can't do it all ourselves. We need help. We have to use our team members for sure. So, you know, using team members is really great. You can move on to the next slide, Michelle. You know, look at who can do something, who currently is doing something, and who should do something. So a great example is taking a blood pressure. When I started in practice, I did all my own blood pressures, but over time and with automated machines now, physicians can do blood pressure, MOAs and nurses can do blood pressure, and you can even teach reception staff to do blood pressures if they're using the automated machines. So then you have to look at your workflow and decide who's the best person to do it. So concentrate on those areas of overlap and see who the best person to do it is when you're looking at that. And we have an upcoming slide here. I don't know if Melissa Waddell is on the call, but she's the president of the Primary Care Nurses of Alberta. And there's a lot that they can do for us. Their scope is pretty broad. So this is just a list of some of the services that they can provide for us in our clinics. So that's really helpful. All right, Jarrett, what do you think of this one?
Yeah, so for this one, I think I'm actually on board with this idea. The using your team is really, really important, and I think that's something we really need to emphasize. I know there's a lot of concerns about where the funding for additional team-based care is, but even with a small dedicated team, you can do a lot. I know in my clinic, we have an RN who has created a multi-page algorithm style type 2 diabetes management flow. So essentially, if we have a patient in clinic for our pod who has an A1C I use over 8, I can refer the patient directly to her, and she will sit down with them. Usually it's for about a half hour. We've been tracking numbers, and it takes about a half hour of her time. And she gives them really solid education, figures out where they've been at on sort of a treatment journey, figures out what a next appropriate step is. And then me and her have a quick debrief for about 2 minutes. I get to see the patient, so it's a billable service. And in that time, I'm seeing 2 other patients. So I end up way ahead, and it's providing really, really good quality of care that's not rushed for that patient. It's a great use of nursing time. Patients have really found it a good way to get the care they need. And then we're able to set up the follow-ups. And so that nurse is seeing about 10 unique diabetic patients on my panel per month to help manage this. And this is something that lots of other people can be incorporating to help ease up that demand.
Great, thanks. So I think we just need to address a couple of things that came up in the chat. Ernst, I see you're on the call, and I believe you said you're using Prescribe IT. Do you want to talk just briefly about it for us?
Yeah, thanks, Janet. I think many of you on the chat probably use it as well. It is an initiative that's a national initiative. So the kinks has been sorted out at a national level. The PIA is supported in the application process. So if you sign up for Prescribe IT, I really think that this has been the smoothest sign up for me of any of the add-on services that I've used. A team will come to your clinic, they'll assess the clinic, and they'll provide you with the documentation. You send it in, and you'll be live relatively soon after that. It definitely makes a difference in my clinic, specifically regarding prescription refill requests. Instead of my staff having to receive a fax, print a fax, give it to me, I sign the fax, they fax it back. Everything comes through Prescribe IT. I can deny or I can approve the request. You can also send messages to the pharmacy through that. And then patients really value it as well. It saves them an extra trip to the pharmacy, or perhaps even some time at the pharmacy to wait for their prescriptions to be filled, because by the time they leave the clinic, their prescription is already at the pharmacy and they are able to process it. So definitely a benefit for both patients and for providers, and something that you should strongly consider for efficiency in the clinic.
Okay, and Melanie, do you know which EMRs are, because we had a note in the chat that Akiro isn't offering it yet. Are the other EMRs offering it? Do you know, or can someone put in the chat what EMRs do offer it maybe? Okay, so we've got that MedAccess offers it. HealthQuest, PS Suite. Okay, so we had a question, is everyone not just using electronic fax direct to pharmacy straight from the EMR? How is this different? So the prescription goes in the cloud basically, and then the patient gets their prescription when they go to the pharmacy. So you don't have to print anything out. Faxes still can get lost. Patients can still lose their prescription. So it avoids all of that. And you don't have, it's not going to one specific pharmacy until the patient walks into that pharmacy and retrieves it. So I do a lot of faxing from my EMR to pharmacies, but sometimes patients change their mind and they want to go to a different pharmacy, or they want, I don't know if any of you have this situation where they want one prescription at one pharmacy because it's cheaper, and they want another prescription at another pharmacy, and it gets very complicated. So this takes that away. Does anyone else have any comments about Prescribe IT before we move on?
Janet, if I can just perhaps add something else. I think what's different from an e-fax with this is the prescription, you fax immediately from, or you send the prescription immediately from your medication list. So when you make your changes in your medication list and you update your list, that's the list that is being faxed immediately from there. And when I get a request in, it automatically populates my medication list with that request, and I just approve it. So I don't have to enter all the prescriptions or refill the prescriptions in my medication list. So it definitely saves 1 or 2 steps over e-fax method.
Oh, yeah, that would save a lot of time. That sounds great. Okay, I was having a hard time keeping up with the chat. Oh, okay, we've got a question about cost. I believe there's no cost, correct? Yeah, there's no cost involved. Is there anything else, Michelle, that we need to address in the chat? I was having a hard time keeping up.
Yeah, me too. I think a lot of the answers have come up in the chat itself. There's a question about, yeah, it works for triplicates, and that was answered yes. Yeah, I think I think our experts in the audience have answered a lot of the questions that are in the chat about Prescribe IT.
Yeah, not needing to fill in the triplicate prescription with the patient's demographics. That's a big time saver too.
Oh, and does Prescribe IT auto update the patient medications in the EMR?
I think Ernst answered that, and he said yes, it does. So that's a huge win for us as well.
Okay.
Big time saver. Okay. So now we're going to go to our breakout rooms and just talk a little bit about some tips that you're doing in your rooms. So in your clinics, sorry. So, you know, have you made any changes to improve access for your patients? How do you keep up with the demand that your patients have for appointments, and what tips do you have to share for others? So we'll go to our breakout rooms. We're doing them by zones today, and then we'll gather back in about 20 minutes or so, 25 minutes. So we had in Edmonton zone, we had a couple of physicians, but we had a really strong group of practice facilitators. So that was awesome to see them on the call today. And we talked a little bit about some things that team members can do to help physicians out. So with screening and with transitions and some of those things. What did you talk about in the Calgary and South Zone room, Jarrett?
Oh, we got into all kinds of stuff about just different access struggles, ways in which we can kind of optimize team, how to try to figure out ways to set that up. We were getting a little bit into panel size discussion and sort of no-show pieces as well, which we ran out a little bit of time on. I'll try to answer a bit of that in the comments.
Great. Lindsay, what were you with the North and the Central Zone there?
Yeah, we had a bunch of docs and practice facilitators and nurse practitioner on our calls. So we talked quite a bit actually about just carve out spaces or squeeze in type appointments for urgent access, and how patients and how clinics manage that, as well as kind of however they're named, walk-in clinics, urgent access, timely access clinics for unattached patients. We also talked about, you know, the pressures of in a rural community of physicians leaving the community and what that actually means, right? So what that means is TNAs creep up, driver's medicals end up going to the emergency department, and there's maybe not a lot of solutions, but commiseration with it, and definitely a discussion on the priority of trying to maintain continuity with the patients that we're caring for. We also had a good discussion too about allied healthcare professionals, how we can offload to team role of nurse practitioners in this, but again, you know, province-wide, but also in the rural context, it's really challenging to hire NPs into positions.
Right. Yeah, nurse practitioners can be a great addition to a clinic, but there aren't that many of them out there. So Alberta, it's, you know, the way the government makes it seem like that there's all these nurse practitioners ready to jump in, but the reality is there aren't that many. So we'll see where things go. Michelle, do you want to do our wrap-up slides for us?
Sure. Yeah, great conversation. It sounds like everyone. So thanks for participating with us today. I wanted to just mention that the One Nail at a Time Insights for Building Your Patient's Medical Home podcast. I'm going to sound really cool. We just dropped a new one. And it's called A Closer Look at Primary Care Nursing with Melissa Waddell. And so she goes into much more depth about the scopes of LPNs and RNs in particular. And like you saw in the document that we had up on the screen there, there's actually a surprising, I personally, I was surprised at the vast scopes of both those groups. So if you're interested, you can give that a listen, and we'll put that in the notes that we send out, so you can find the link easy. And our next session will be in 2024, January 17th. The topic is Calming the Waters, Techniques to De-escalate Conflict. So of course, that will apply whether in your clinic or if you're on a board or sitting on committees. Conflict is everywhere, even at home sometimes. So we'll give you some tips and strategies that you can try out. And otherwise, happy holidays, everyone, and we'll see you in January. And thank you to the Practice Facilitator Network for joining us. You added a lot of flavor to today's session, so thank you.
Thanks, everyone, for your great contributions.
Thanks, everybody.